Next up is Alzheimer's disease, which is one of the leading causes of cortical/senile dementia. In fact, one of the best prime ministers India had, Atal Bihari Vajpayee sir. Even the Kargil war for us, we lost him due to Alzheimer's disease, a complication in 2018. I'll describe the reasons for death in Alzheimer's disease in about few seconds from now. Then one of our former defense minister, George Fernandez sir, we lost him again due to Alzheimer's disease. You can see him in that Air Force jumpsuit dress in blue. And then the image right on top is of Ronald Reagan. He was a former United States president in the late 80s, and he was instrumental in maintaining peace between USA and the former Soviet Union, that is USSR, before that USSR collapsed into so many states. But the point is, why I'm telling you this is to sensitize you to the fact that if great world leaders of even a developed country like USA will develop Alzheimer and will finally die because of complications of Alzheimer, that tells you that we don't have too much to offer as far as management of the disease is concerned. Yes, we do have medications. I'll talk about recently approved monoclonal antibody for management of this condition as well. But overall, what I want to say is that the disease causes an intense amount of not only a financial burden, but intense amount of emotional trauma on the family members of persons suffering from Alzheimer's disease, because these people themselves are unaware of the deficit, and that is why we use the term anosognosia. In the later part of this discussion, I'll describe the four A's of this condition also that I'm saying verbally at the moment. That would be amnesia, forgetfulness. Then there's a aphasia, apraxia. That's because of the involvement of the parietal lobe, because dominant parietal lobe damage will cause aphasia, non-dominant parietal lobe damage will cause apraxia. And more importantly, in these patients, memory part is anyway affected. So I said amnesia, and they're unaware of whatever is going on with them, to the level that they might be wearing the same pair of clothes for days altogether and would be urinating in the same pair of clothes. You see, if a person ends up soiling his clothes, at least he will try to clean himself. No. But these patients might be wearing the same pajamas in which they have urinated and defecated and have made no attempt to clean themselves. Guys, Alzheimer's disease that we're discussing at the moment will subsequently in late stages cause a patient to develop mutism. Due to this, he will not be able to even tell that he wants to pass urine and stool. So, Alzheimer's disease patients overall will be one of the most unhygienic patients that you'll come across, because this chap would not have shaved for a very long duration. His nails are gonna be jet black. His mouth is gonna be smelling bad because he's not brushed his teeth. He doesn't know how to brush teeth. More importantly, he will be urinating and defecating at the same place where he's eating, and he'll not make any attempt to clean himself. And he might be wearing the same pair of clothes, like I said, for days altogether. And because of this extreme filth, there's a possibility that in India, the family members might even turn this guy or might kick this old man out of the house. And this guy might be living outside a temple in a disheveled state. He might be wandering aimlessly. The temple is 2 kilometers away from his residence. This guy does not know the way back to his house. Even if you inquire him his name, if you inquire about his personal details, he'll not remember anything, because I said there would be amnesia, there would be initially loss of short-term memory and subsequently long-term memory as well. So this guy might be a beggar on the road, wandering aimlessly in a semi-naked state or a naked state, and he's urinating at the same site where he is eating. Like, there's food in front of him and he would be urinating at the same place. That's the amount of disability this disease would be causing. So the leading cause of death in Alzheimer's disease ends up to be aspiration pneumonia, because in any, even in Parkinsonism, ultimately, like I described in Parkinsonism, Muhammad Ali, the biggest boxer of all times, again died because of Parkinsonism. And even in case one of the reasons for death was aspiration pneumonia, the same thing happens in Alzheimer's disease as well. Apart from this, because these patients would not be in a position to eat by themselves, even if you have mercy on them, no, like you have Alzheimer's disease patient admitted in a hospital and you trying to feed him, like this guy, yeah, the hospital staff has placed food in front of him and have gone away, and you just took pity on the old man out of compassion as a doctor. You decided, okay, I'll try to feed him. Now if you bring, a spoonful of rice or food near the mouth of somebody, you expect the person to open his mouth. This guy will not even open his mouth. Even if you forcibly open the mouth and put food in the mouth of this guy, he will not know how to chew. Can you beat that? You're putting food in the mouth of somebody, the guy doesn't know how to chew, and obviously because of the food, there would be some saliva that would be occurring, salivation that would be occurring. So there would be saliva dribbling from the corner of the mouth, there would be food dribbling from the corners of the mouth onto the vest of this person, and then, this guy might urinate and in the plate, or he might urinate at the same spot where he's sitting in the hospital bed. So it's very difficult to manage these patients. That's why, in America, there is still institutional care. There are special nursing homes where these patients would be admitted and would be taken care of, and they'll at least provide them with adult diapers. In India, the concept of diaper for adults is so alien that even in upper middle class, no, when you tell somebody that your dad would require a diaper, they just look at you and say, "Why? I mean, children require diapers. Why does my adult require my? Why does my dad adult require a diaper? Can't he go to the bathroom by himself? And he's so unhygienic, he's so filthy." So aspiration pneumonia, malnutrition, and then because these patients are most of the time bedridden, so there is a high probability that they can develop deep vein thrombosis that can contribute to even pulmonary embolism. In old age anyway, concomitant coronary artery disease can be present, so heart disease can be a contributory factor responsible for death in these patients. And if they keep on lying in the bed, then they can develop bed sores and they can get infected also. So secondary infection overall could also be contributing to development of death. So they will be writing multiple things in the MCQ, but if we have to select the single best answer for the leading cause of death in Alzheimer's disease slash Parkinsonism as well, the answer should be given by you as aspiration pneumonia. The topic that we're discussing at the moment, guys, is the leading cause of development of cortical dementia, that is Alzheimer's disease. But recently, in one of the MCQs in the exam, what they did was that Alzheimer's disease was not in the options. So let's just quickly revise what are other conditions where we can be having cortical dementia apart from Alzheimer's disease. Obviously, this is the leading cause. Then we have to remember Pick's disease, which is called as frontotemporal dementia, is also cause of cortical dementia. Apart from this, vascular dementia, that's the second most important cause of dementia. Stroke patients will end up developing dementia. So vascular dementia, the dementia with Lewy bodies, where you could be having visual hallucinations, you could be having REM sleep disorders, are examples of cortical dementia. Even CJD, that is Creutzfeldt-Jakob disease, or if subdural hemorrhage is not treated. I'm not writing for SDH because mostly treatment of SDH would occur, but in earlier times when if SDH was missed or if SDH was not treated, then it could contribute to development of cortical dementia because of direct pressure on the gray matter from outside. But these are like couple of other causes for development of cortical dementia that we should be remembering. I'll list the causes of subcortical dementia. And subcortical dementia will be having involvement of thalamus and the basal ganglia as well. So causes of subcortical dementia like Parkinson's disease, Huntington's disease, just to give you a heads up, would be listed subsequently. The minimum messages at the moment are leading cause for development of cortical dementia is Alzheimer, but do take care of the ones that have written in red. And over and above this, I said the leading cause of death in this condition is aspiration pneumonia, and the disease takes a huge emotional toll on the, I would say, the emotional health question of family members as well, because it's really sad for a son and a daughter to be sitting with their dad and not the dad does not recognize them. And I mean, at the same time, the unhygienic component is very much present in these patients. And nowadays, we are talking about the concept of preclinical Alzheimer's disease so that we can identify the disease relatively early. In fact, in a large number of cases of Alzheimer's disease, there is also possibility that before dementia sets in, before person starts having short-term memory loss followed by long-term memory loss, the person might even start having development of partial seizures and GTCS. That is again an MCQ statement to be remembered, because normally we read about 4 A's, right? Like I was saying, amnesia, aphasia, apraxia, but then partial seizures and GTCS can occur. So it's not a guarantee, but yep, seizures can occur before dementia onset. So this could be one of the MCQ statements that seizures are a presentation in Alzheimer. You say all are presentation of Alzheimer. So you just need to remember that even seizures can occur before dementia onset. And nowadays we are trying to identify the disease even before the dementia has occurred in a patient. It looks like very surprising to read this term for the first time, preclinical Alzheimer's disease. It's giving us a window of opportunity to intervene, because our objective is now, like, once the disease, we what we have seen is once the disease will occur, the neurodegenerative process is fairly aggressive. So our objective is to pick up the disease relatively early. So meaning of the word preclinical Alzheimer's disease, as is gonna be visible from even English, is that we are either having CSF biomarkers. I'll just talk about that CSF biomarker in few seconds from now, or PET biomarkers available. So we can be using technology to our advantage. And the meaning of the word preclinical Alzheimer's disease is that CSF or PET biomarker evidence is present in the absence of dementia or in absence of clinical symptoms. I repeat that once again, preclinical would mean that we are having laboratory based evidence. Either the CSF biomarker or a PET biomarker evidence is present in the absence of clinical features in this patient. The clinical features will be discussed in detail in the subsequent slides. Let's look at one of the CSF biomarker that we have available at the moment, and that would be with respect to A beta amyloid. You are aware from your basic sciences classes and from pathology classes that in Alzheimer's disease there would be presence of A beta amyloid in the neuritic plaques. I'll talk about the position of neurofibrillary tangles and neuritic plaques on my subsequent slide, but I think from your baseline classes you are all aware regarding A beta amyloid. Just to remind you once again, if you read about A beta 2 amyloid, then this is one that is incremented in dementia, which is seen in patients who are undergoing hemodialysis. So, in case you get a MCQ that says dialysis dementia is associated with, then answer is A beta 2 amyloid. But on the other hand, if it talks about Alzheimer's disease, then it is A beta amyloid. And you just need to put up a small number here for remembering that the CSF level of A beta 2, A beta 42 levels in the CSF are found to be lesser. In fact, in some MCQs in the CSF, he might even mention a ratio of A beta 42 divided by A beta 40, and the levels are found to be lesser. So this is a CSF biomarker. The values are found to be relatively lesser. We also have more advanced PET scans available. So he might talk about amyloid PET. He might talk about tau PET. So these are like newer techniques by which we can identify the preclinical Alzheimer's disease. And in fact, he's given a very strong statement that preclinical Alzheimer's disease, where there are no clinical manifestations in a patient, can predate the symptoms by as long as 20 years. He might develop manifestations of Alzheimer's on maybe 70 years onwards, but in his 50s only, the CSF biomarker will turn out to be positive. And why we need to note this is because I said, because they could be as long as a window period of 20 years from preclinical Alzheimer's to development of clinical Alzheimer's disease. So that is where the main research is focused at the moment, that can we do something, because we have seen once the disease will occur, it can have a fairly aggressive progression. In a couple of years, patient will become bedridden, will be having mutism, will be having unhygienic status, will be incontinent, they might be passage of stool. So because we have seen already the degeneration, as a result of it, now our research is focused on early identification of the disease. The question then arises, what are the neurotransmitters that would be involved in pathogenesis of Alzheimer's disease? So you are all aware again from basic sciences that acetylcholine deficiency would be seen. But nowadays you will notice that in large number of MCQs, he might ask you a combination of neurotransmitter defects that could be seen in Alzheimer's. So it is acetylcholine deficiency, everybody knows. But over and above this, you would have also read in basic sciences that even norepinephrine levels and serotonin levels are reduced. Acetylcholine deficiency will mainly be demonstrated to be less in nucleus basalis or Maynard, and this nucleus basalis or Maynard would be located with respect to the hippocampus. And where is hippocampus located? That's deep inside in the temporal lobe. In fact, it's present with respect to the medial part of the temporal lobe. But then acetylcholine deficiency is documented to be present with respect to nucleus basalis or Maynard. Then as far as norepinephrine deficiency is concerned, that would be with respect to locus coeruleus. And then the third one would be serotonin deficiency. That's going to be with respect to dorsal raphe. So one, you need to get these terminologies right with respect to neurotransmitters. Acetylcholine aspect, everybody knows that nucleus basalis or Maynard, but apart from that, norepinephrine and serotonin aspects are also to be remembered. Now, if he says in the question that which is the earliest part of the brain to be involved, or instead of saying earliest, where is the most severe degeneration present, then the answer for both of them is the same. A bit of those integrated kind of questions, will they try to squeeze a bit of pathology in the options as well. The earliest and the most severe degeneration will be present in the medial part of the temporal lobe. If he wants to make it much more anatomy oriented, then instead of saying medial temporal lobe, he might even use terms like entorhinal cortex and perirenal cortex. I repeat that once again. More anatomical oriented terms would be like entorhinal cortex and then perirenal cortex, which are components of the medial part of the temporal lobe itself. And once they are involved, then subsequently the disease will go and involve the inferior part of the temporal lobe, and then the lateral part of the temporal lobe. So it starts in the medial temporal, goes to inferior, and then to the lateral temporal lobe. That's where the inside where the hippocampus is located. You see, hippocampus is primarily for short-term memory. In contrast, when it comes to the long-term memory, the long-term memory is going to be mainly located in our neocortex. I mean, short-term memory is going to be mainly located in the hippocampus, and the long-term memory is going to be located in the neocortex. And we'll just say a funny fact here before we go forwards, that why do they say that you must be doing at least three revisions, is because it has been shown in clinical studies that if you read the same data again and again, it requires at least three readings for short-term memory to be converted into long-term memory. Lots of time it happens, no, that when we study and then we do MCQs, after a few days you forget the topic and you can't even remember why answer to a particular MCQ is A or B or C. And we all have that universal problem that bhul jate hain, right? So that's because short-term memory has not been converted into long-term memory, and what is required for conversion of short-term memory into long-term memory is to feed the data at least three times. So if we go in the exam with that long-term memory, our performance in the MCQs and grand test will be better as compared to when we are operating on short-term memory. So in case you have done your one revision or two revisions and the GT scores are not improving, don't worry. I mean, it has been validated in clinical studies that once you have done those three times, the circuit has been bombarded with lot of data. That's when the short-term memory gets converted into long-term and the performance will gradually start improving. Coming back to the agenda, I said neurotransmitters involved are three of them: acetylcholine, norepinephrine, serotonin, and this is where the most severe degeneration would be present. And that the disease would not only involve the temporal lobe but even the parietal lobe. And the involvement of the parietal lobe will explain why, if the dominant parietal lobe is involved, you'll have aphasia. And when the non-dominant parietal lobe would be involved, there would be apraxia developing in these patients. So in the subsequent slides, those A's would be coming up once again. The question in the mind of the examiner now, and the question in the mind of even the relatives of this patient would be that why is it happening to my father, or can it happen to me when I am my father's age? So you also need to remember the aspects with respect to which chromosomes can be defective with respect to Alzheimer's disease, and what are those numbers, what are those genes which are to be remembered. So there are total of four numbers to be remembered: defect of chromosome 1, chromosome 14, 19, and 21. That is 21 even know is related to Down syndrome. So these are the chromosomal defects which are associated with development of Alzheimer's disease. For chromosome 1, the gene that is defective is by the name of presenilin 2. And if you contrast that with defect on chromosome number 14, this would be for a gene by the name of presenilin 1. The main crux at the moment of the discussion is that presenilin 1 gene, which is defective with respect to chromosome 14. I mean, you need to remember that presenilin 1 gene is not related to chromosome 1, but is related to chromosome 14. And the gene that is related to, I mean, the gene that is defective on chromosome 1 is presenilin 2. Just get the numbers right. With chromosome 1, it is presenilin 2 gene that is defective. With chromosome 14, it is presenilin 1 gene that is defective. So you need to get this data right. And then with respect to chromosome number 19, lot of interesting things coming up here at the moment. That is a gene by the name of ApoE gene. That is apolipoprotein. Normally we read no ApoA, ApoB with respect to lipid metabolism. Even ApoE plays a role with respect to cholesterol transport. ApoE gene and the protein which it codes for plays a role with respect to lipid transport. And then there is a allele with respect to this, which is called as ApoE4 allele. And the presence of this ApoE4 allele increases the risk of development of Alzheimer's disease. This is in contrast to another allele which is to be remembered for the exam, that is ApoE2 allele, and this tends to reduce the risk. So you just need to get this data again right, that ApoE4, the number 4 is coming a little later, so it will increase the risk or the severity of acquiring the disease versus ApoE2, which decreases the risk. In fact, there are only two things that decrease the risk of Alzheimer's disease. Everything else that I'll be describing before you, like diabetes mellitus, hypertension, hyperlipidemia, all atherosclerotic risk factors increase the risk of development of Alzheimer's disease. There are only two things for which he has not given any explanation, but he says that in peer-reviewed data we have seen that NSAID usage, and the second he has mentioned regarding ApoE2 allele, These are the only two things which have been shown to be protective with respect to Alzheimer's. In fact, it would be wrong word to say protective. It's just that the risk of development of Alzheimer's disease would be relatively lesser. But metaphorically or semantically speaking, from English language perspective, I can say that the MCQ might even use the word protective in this particular case. This is only on comparison basis that NSAID usage or ApoE2 allele are shown to decrease the risk of Alzheimer's, in contrast to all standard atherosclerotic risk factors being responsible. In fact, for chromosome 21, I can say that the gene would be called as APP, that is amyloid precursor protein gene, and there would be an extra copy of this gene, right? Because 21 chromosome 21 defect is trisomy 21, so there would be an extra copy of this gene present, and this extra copy is the reason for the cerebral amyloid accumulation, the A beta amyloid that I'm talking about. And this would be accumulating between the neurons. The neuritic plaques that we study in pathology, that's the accumulation of A beta amyloid between the neurons. I'll just try to draw a line diagram to explain this. Like, let me say this is a neuronal body, and then is the axon. This is another neuron, and then an axon subsequently. So this particular shading that I'm doing at the moment is for the presence of A beta amyloid, and the pathology people will be using terms like neuritic plaques with respect to the A beta amyloid accumulation, which is going to be occurring outside the neurons. And there are monoclonal antibodies that I'll be describing subsequently, which have been designed, which will tend to reduce the accumulation of A beta. In fact, they've been shown to reduce this A beta accumulation in the neuritic plaques. And then in Alzheimer's disease, we'll also read about intraneuronal finding that I'm currently showing in green, and this is what is called as neurofibrillary tangle, NFT. So why are these neurofibrillary tangles accumulating, and what is the protein which is present here? Well, the protein that is present here is the tau protein, and this tau protein, when it hyperphosphorylated tau protein that accumulates here, this basically interface with microtubule assembly. You see, when the cell has to do metabolism, the microtubule assembly would be occurring, and the hyperphosphorylated tau, so just put a H for that, hyperphosphorylated tau protein interface with microtubule assembly, and this causes a defect with respect to the metabolism of the cells, and therefore causes creation of these neurofibrillary tangles. So therefore, hyperphosphorylated tau protein accumulates intracellularly inside the body of the neuron, and neuritic plaques are present extracellularly, and the load of these, I mean, more is the neuritic plaques, more is the neurofibrillary tangles, the combination, the more these will increase, more will be the severity of the disease. I mean, severity of Alzheimer's disease is related to presence of neurofibrillary tangles. That's one, that's the first point, intra neuronal, and then he can ask you extraneuronal, that is neuritic plaques. Both contribute to the disease burden. The only point I would like to say is that in old age also A beta amyloid can be present. A beta amyloid accumulation, which has been shown with respect to neuritic plaques, can be seen in old age, and they may not be having Alzheimer's disease. So, I mean, alone A beta is not sufficient for diagnosis. We also need to prove demonstration of, I mean, this hyperphosphorylated tau, and that is why whenever we read about Alzheimer's disease, the pathologist will always use the term taupathy. So I'll subsequently make a list of what are those taupathies that you're supposed to remember for the exam, and why all this is happening. Why are we having these NFTs? Why are we having this neuritic plaque accumulation? That's because of defective chromosomes which are related to these genes. I mean, the defect is on the gene, in fact, and the defect in the gene translates into the following manifestations that I've described before you at the moment. And the most important mistake that will occur or can occur in the exam with respect to these genes is that presenilin 1 gene, which is defective, is not with respect to chromosome 1, but it is seen with respect to chromosome number 14. Whereas in contrast, when it comes to chromosome 1, the defective gene to be remembered is presenilin 2 gene. So once we get this data right, presenilin 2, presenilin 1, then ApoE gene and amyloid precursor protein gene, the extra copy of which contributes to this cerebral amyloid accumulation, then we are good to go as far as the clinical manifestations of the disease are concerned. And I'll just say a few more things with respect to the risk factors. I mean, traditionally we read about obviously hypertension, diabetes, hyperlipidemia, hyperhomocystinemia. They all, obesity, centripetal obesity, they'll all contribute to it. But even low folic acid levels, Elevated low folic acid in turn would contribute to elevated homocysteine levels, are contributory factors for development of Alzheimer, and even people with low education are tending to have a higher. That's just documented in studies that person who's had a low educational attainment, and the plausible explanation for the same can be that because it did not use this neuronal reserve sufficiently. I mean, if a person has done, let me say, a PhD in mathematics, or he's done a PhD in physics, or he's a physics professor, then that person would be having lesser chances of development of Alzheimer's disease as compared to an individual who's having a relatively low educational attainment. Let us now enumerate a couple of causes or tauopathies where the mnemonic to be remembered is ACDP4. So A would be for Alzheimer's disease, alphabet C is for corticobasal syndrome. The peculiar manifestation that we encounter in corticobasal syndrome would be like this person will light up a cigarette with his right hand, and this left hand will suddenly come, snatch the cigarette from between the lips, and throw it away as if the left hand is having a brain of its own. So, very peculiar manifestation that I've described here is called as alien limb phenomenon that is seen with corticobasal syndrome, which happens to be an example of a tauopathy. Then alphabet D is for Down syndrome. Now, in Down syndrome, most of the time, the congenital heart disease that is present is ostium primum ASD or endocardial cushion defect, and that can cause congestive heart failure and usually causes death in children, especially in India. Or children of Down syndrome can die because, if not because of heart failure, they can die of recurrent pneumonia. But if a Down syndrome patient is able to survive beyond 35 years of age, then the manifestations that develop in these patients with respect to dementia would be identical to what you would get in a person at, let me say, 80 years of age. So, because the manifestations of dementia coming at as early as 35, 40 years of age, we use the term pre-senile dementia. Like in the starting, I mentioned cortical dementia. I mentioned a couple of causes of cortical dementia, ranging from Alzheimer's to frontotemporal dementia, and even Creutzfeldt-Jakob. At the moment, I'm describing tauopathies, and I've incorporated Down syndrome, which is related to chromosome 21 trisomy. The extra APP protein contributes to A beta amyloid accumulation, and that's why the pre-senile dementia would come up. And this is itself a one-liner MCQ to be remembered. Then alphabet P would be for first progressive supranuclear gaze palsy. It has been discussed in the topic of Parkinsonism, and one of the highlights of this condition would be a impaired downward gaze. So this MCQ will begin by describing a person in his 60s and he's having recurrent falls. But the reason for this recurrent falls is impaired downward gaze, because see, if you or me cannot look downwards, then we cannot see the surface that we are walking on, and if it is uneven, we can fall. It will even be more difficult in climbing stairs. So impaired downward gaze. And the second manifestation that is seen in these patients is that they're trying to keep their head slightly elevated so that they can look downwards. So there would be a severe neck hyperextension, or retrocol is also described. So PSP, progressive supranuclear gaze palsy, will have bradykinesia rigidity, but there would be no resting tremor. Resting tremor, asymmetrical resting tremor, is a classical feature of typical Parkinsonism, but PSP is a atypical Parkinsonism, which is why there would be no resting tremor, only bradykinesia rigidity described, along with features of impaired downward gaze, and retrocol is also described in the question. The next would be PCAM, that is pantothenate kinase associated neurodegeneration. One of the varieties of pantothenate kinase associated neurodegeneration is NBIA, that is neurodegeneration in the brain with iron accumulation, where you read that famous MCQ of eye of the tiger appearance on an MRI brain. Again, I've covered NBIA in the topic of Parkinsonism, and the neurodegeneration in brain with iron accumulation as a condition per se presents with features of basal ganglia involvement as well as neuropsychiatric manifestations, but obviously there's no KF ring, because the age of presentation of PCAN can be same as that of Wilson disease, but then Wilson would be having KF ring, and copper levels would help in differentiation. The next condition that I'm describing is called as dementia pugilistica, or instead of dementia pugilistica, it is seen in boxers and is called as punch drunk syndrome. And then the last P would be for post-encephalitic Parkinsonism. This would be again a second. This in fact what I'm writing at the moment is a secondary Parkinsonism. Like I was mentioning for PSP, that is atypical, but here I'm saying secondary because this is post-encephalitis damage to the basal ganglia substantia nigra. So it's a post-encephalitic Parkinsonism. And as far as this mnemonic of ACP4 is concerned, I think I can just put artificial line here to say that the first P will not usually cause a problem. It is ACDS DP, that is Alzheimer, then corticobasal syndrome, Down syndrome, and finally progressive supranuclear gaze palsy. But equal amount of respect for MCQs needs to be given for PCAN, then Punch-Drunk syndrome, and post-encephalitic Parkinsonism as causes of tauopathies. What I say next is very primitive, very baseline data, so I would like you to listen to it. No need to note it down. See, the topic that we're discussing is Alzheimer's disease. In this, the neurotransmitter that is compromised is acetylcholine. There are multiple areas of the brain that are involved, but one that I have specially spoken about is nucleus of basalis minor. And then from the pathology perspective, he can write the word hyrona bodies. Now, because it's mainly for this word hyrona bodies that I came into, or I decided to write this data, because these hyrona bodies would be a intraneuronal finding. Like I was saying, A beta amyloid is an extra neuronal finding, but hyrona bodies are obviously intraneuronal, and this is where the hyperphosphorylated tau protein will be present that will interfere with the microtubule assembly and affect the stability of the neurons, and we have a neurodegeneration. In contrast, Parkinson disease would be having deficiency of dopamine. The area of the brain that would be involved in this case is substantia nigra compacta and reticularis, and then the inclusion bodies that are present in Parkinson disease are called as Lewy bodies, and these Lewy bodies would be having this protein that is alpha synuclein protein. So most of the time, the questions that would come to you would be like, all are examples of tauopathies or all are examples of synucleinopathies, except, and as far as synuclein is concerned, it is with Parkinson disease, that's to be remembered, whereas tauopathies, the list is what I've enumerated before you at the moment. The data that I mentioned in yellow color, I think, is very simple and primitive, so no point of noting it down and trying to remember it. And yes, the slide on the extreme right hand side just reiterates what I said, that this is a amyloid plaque. This is where A beta is present, and monoclonal antibody that I'll describe, the recently approved one, the drug approved in 2021, is the question that I'm talking about again and again. I'm not said the name because I'll mention the name in a while, but that interferes with the development of these amyloid plaques and thereby tends to reduce the deterioration of the brain of the patient. It can be used in patients with early onset Alzheimer's disease. And inside the neurons, well, we have presence of these neurofibrillary tangles, and these neurofibrillary tangles is what I was talking about with respect to hyperphosphorylated tau protein, which interferes with microtubule assembly. Now, on the basis of this background information, we are in a better position to remember information with respect to the clinical manifestations that are seen in this condition. My main focus will be to talk about 4 A's that we can be seeing in these patients. Before the onset of dementia, before the onset of dementia, we might be having presence of seizures in these patients as well. I've written a plus minus to say that seizures may or may not be predating the development of dementia, and the type of seizure that can be seen can be either focal or can be generalized seizures as well. Then this person will first start developing mild cognitive impairment, where person will himself try to tell you that he has become more forgetful, and initially the family members might find it very funny also, like this person kept his cell phone in his left breast pocket and he's forgotten where the cell phone is, and he's hunting for that cell phone in the entire house. So initially, and son and daughter will find it very funny that, oh, my dad has become old and is becoming forgetful. And that is the time when this person is also saying that, I don't know, I mean, I just keep car keys somewhere and I tend to forget it. Family members are also realizing that there is something wrong with the memory of this guy. The later part of the disease will obviously be much more severe, but at the moment, what I'm trying to say is mild cognitive impairment is memory loss is noticeable. And this memory loss, initially it is funny for the entire family that, oh, my dad is getting old, but then they realize that there is a substantial amount of handicap because he tends to forget instructions that were given to him. Like maybe his wife is an old person, retired person, wife said, okay, can you just get some vegetables from the market, and though the instruction was given to him, he forgot it. So memory loss is noticeable by the patient himself, and memory loss would be later part. There might be anosognosia. He will be unaware of the deficit, but initially the memory loss may be noticeable with respect to the patient and the relatives, and we'll also be doing a standardized memory testing as well. So we will talk about mini mental score examination, or we'll talk about a MOCA score for these patients. So we are able to demonstrate the presence of dementia even on a formal psychological testing as well. That would be MCI, mild cognitive impairment. Our objective nowadays is to pick up the disease relatively early, because Later part of the disease will be substantial to the level that I can say that most non-medicos would even realize that their dad's brain is not functioning like what it used to do earlier. Like at this particular point of time, this person will be totally incapable of tracking his finances. Like you would have noticed, no, old people are very particular about especially how much money they are carrying. Like this old man went to the vegetable market. If you and me will go for shopping, no, we don't even know how much money is in our pocket. And nowadays, in the scenario of e-wallets and Paytm and all those, I mean, nobody carries hard cash. But let's go back a few years before these electronic wallets were available, and a person, old man, is going out of his house to buy some vegetable. So old man, normally old people are more conscious about money, so they tend to remember, okay, how much money am I carrying, and how much I did give to the vegetable vendor, how much change is he supposed to give me back. But in this case, I mean, this guy will keep on messing up with calculations, so there would be a dyscalculia developing in these patients. And as I said, they're not able to follow instructions, and because they're not able to follow instructions, then day to day household activities will also be affected, or ability to perform daily chores can be affected. In fact, if he's trying to do, a old man is trying to do some part-time job, or let me say he's retired as a professor, but then he writes a book, and if he's trying to write a book, he'll tend to forget the data. So he's not able to follow instructions. He will not be able to do driving. Like a lot of time these patients might get lost. You see, nowadays is the era of GPS, and we trying to switch on the GPS on a mobile and we keep on driving. But in earlier times, I mean, there was no GPS available. You have to memorize a route, and this guy will forget. So it will be very, I would say, distressing time for both because he'll tend to get lost. He can end up with an accident. See, if you're driving on a road and you don't know the way, even if you and me are healthy people and you're driving on a road, you don't know the way, you tend to get a little worried. And if this guy is not able to find his way, he could end up with a little lapse of concentration and end up with accidents as well. So lots of time minor accidents. I mean, a lot of time family members will say, my dad has become old, he has become more forgetful, and he has had a recent accident as well. That's because he was distressed by the fact, he was distracted by the fact that he cannot find his way. That is why driving, ultimately these patients will have to give up the aspect of driving. Even when it comes to grocery shopping, it would be difficult for these patients. In fact, I can say that family members should be advised by you to disable all kind of transactions, mobile-based transactions to be disabled for this person. Because this particular guy might be transferring any XYZ amount of money from his account to another person's account because he's not able to count the number of zeros or remember the amount of money he has to pay. So suppose he has to pay 100 rupees, he might pay 1000. Suppose to pay 1000, he might pay 10,000. So that they can't track finances, they cannot follow instructions. Driving would be not possible. Subsequently, routine shopping, household grocery items purchase will not be possible in this patient. Housekeeping will not be possible for this guy. So let's imagine a scenario where this particular person went out of his house in the morning to buy milk. He has been living in that colony for last 70 years. He's 70-year-old man. He was born in that colony. He went to a milk shop 200 meters away to get milk from there, and maybe he forgot why had he come to that particular shop. Now the milkman or the grocery shopper knows that this person stays in this XYZ house and he comes daily for getting milk, bread and eggs, etc. So he handed him over the packet, whatever routine thing that he is supposed to carry, and he said, okay sir, you can go back home and you can carry all these products. And this guy is sitting at his shop because he doesn't know the way back to his house. In fact, when this grocery shopper or this shopkeeper will try to help this guy might even smile back because he's realizing that a familiar shopkeeper is trying to talk to him. So you will notice that in these patients, initial part of the illness, social graces will be present. Like somebody is talking to you, you will nod your head, you will at least acknowledge the presence of the person, and if the other person is smiling at you, you will also try to smile back also. So in patients of Alzheimer's disease, initially when you talk to them, you will notice that they'll nod their head, they'll smile back at you as well. So social graces and superficial conversation initially, like hi or hello, like somebody said, okay sir, how are you, good morning, or ram ram or whatever. So this guy might even verbatim repeat the word ram ram at that particular point of time. So superficial conversation is possible initially in these patients, and that is why, I mean, for a person who is not belonging to the family, he may not realize that there's something wrong with this person. I mean, this guy, he has lived in that colony for 70 years and he is not knowing how to go back home 200 meters, how to find the way back to his house. So he might be sitting at the grocery shop and the grocery shopkeeper realized that this guy is, just sitting there, and he decided to escort him. And that's where the grocery shopkeeper will think everything is fine. But it is in the later part that we will start having the component of aphasia as well, because the dominant parietal lobe will start getting affected, and the sequence in which with respect to the speech output is affected. First, naming of objects is hampered. Naming of object would mean like this is eggs, this is bread, and this is milk, and this is bread. I mean, if I bought these items from a grocery shop, I know this is bread and this is eggs. So naming of object would be difficult for these patients. Then comprehension, like if you tell them, okay, can you point out to what is bread or what is eggs or routine daily grocery item, comprehension would be affected, and then subsequently fluency loss would be occurring. So that's again important from the MCQ perspective, that because it's easy for anybody to remember aphasia, so he might make it a little difficult for you by asking what is affected first. So it's the naming, then the comprehension, and the fluency that is lost in these patients. And point number three that I described, where I said person can't track finances in a sense that he's not remembering how much money is he carrying in his pocket. Suppose he gave 100 rupees to the person, he will forget how much money did he give, how much change is he expected to get back after doing a particular amount of grocery shopping. So that would be amnesia occurring in this patient. So I'm trying to bring to you that four A's aspect at the moment, and then subsequently the manifestation developing is also apraxia. In apraxia, visuospatial skills would be lost in this patient. Like if I draw geometrical shapes before you, then if I draw a triangle or if I draw a star or any geometrical shape before you, like suppose I draw these geometrical shapes before you, then if I ask you, I don't need to tell you that it's a triangle or an inverted triangle or a star. You can understand the visuospatial skills. We all have that ability to see and draw, and in this patient, the visuospatial skill would be lost. Even this person will not be able to use utensils also. Like I was saying earlier, there is food in front of him but doesn't know how to eat. He doesn't know how to use a simple spoon to pick up a bit of curd and bit of rice and then eat together. I mean, like suppose in a plate, you have rice, you have curd, you have lentils and dal, so we can mix it and we can eat. In this person, that inability to use utensils will be seen. So that is where they become dependent on others, and you to feed this person like a baby. They will not be able to draw geometrical shapes. They will not be able to dress by themselves. I mean, this guy would not be able to know that it is a shirt and this is a pattern, how to wear a shirt or how to wear a pant. So all those things that we don't even think about, no, dressing, eating, drinking, talking, this person would be losing all these skills subsequently. And then there is this famous MCQ where they're gonna give you image where like I can just draw a clock like this. I can say this is 3 o'clock in the clock, and then I can ask my patient to draw a clock like this, and I might notice that he might draw or he might write these numbers like 1 2 3 4 5. I just made 4 marks, no, 3 o'clock, 6 o'clock, 9 o'clock, and 12 o'clock, and he may end up with development of just writing these random numbers, and he may not draw the needle of the clock itself. Or even if you ask Alzheimer's disease patients to just look at the clock, wall clock, and tell what time it is, they may fumble or they may not be able to tell you the time. If you're asking to point to a clock and say, okay, what is the time right now, they may not be able to. They might be looking at the clock but will not be able to tell you the time. And if you ask them to draw a clock like this, they might make a mess of the situation. So the test that I'm talking about is a simple clock face test. And in the exam they've asked, what does clock face test signify? So it signifies mainly presence of dementia or amnesia in a patient. Because see, if I give you an instruction of drawing a clock, first you have to, you see, the apraxia is anyway documented in this case. The visuospatial skill part is hampered. But even before that, even before the apraxia component sets in, if I've given a command to you, short-term memory is what I'm talking about. If I give you a command like, okay, you have to draw a clock, you should at least remember that there is a clock which is to be drawn. So clock face test, if a person is not able to perform, and if amnesia is also given in the options and apraxia is also given in the options, then first answer would be given as amnesia. Because first you have to understand the logic, you have to remember it also. See, first is remembering, I mean, if an instruction has been given to you, the comprehension of the instruction is anyway important. But after that, remembering that instruction is also important. And then you will be able to test out your visual spatial skill. So clock face test is useful for identifying, obviously, apraxia. Will also help you pick up hemi neglect as well. But the first answer for clock face test should be answered as amnesia followed by apraxia. So this guy will not be able to do any crossword puzzles. He will not be able to read a clock. He cannot do simple calculations, and he would be unaware of all the deficit that this guy is suffering from. And now, subsequent to this, bad things are gonna happen. What I mean by bad things is that this guy might be urinating and defecating in the pants, and he will not realize that he needs to change that pair of pants. He's smelling bad. He's like, I mean, reeking of urine smell, and the guy doesn't feel like cleaning himself. Forget about changing his pajamas. His son is exasperated. I mean, sir, I don't know what my dad is going through. I mean, he's become so unhygienic. He passes urine in the cloth and he refuses to clean himself. He doesn't take a bath, and the whole house is stinking because of him. And that is when I said, non-medical people, I mean, they may not have the same amount of compassion and ability to tolerate that urine smell and fecal smell. We in a hospital are able to tolerate everything, right? But I mean, non-medical people, lots of time they might turn their father and mother out of the house because he says, "Hey, the whole house smells bad because of it." So anosoagnosia basically means that the patient is unaware. The meaning of the word anosoagnosia is that patient is unaware of the difficulties. Clockface test is for amnesia, apraxia, as I explained. And agnosia basically means that the patient is going to be unaware of the disability or is unaware of the difficulties that he is going through, and he is putting his family to at I would say a disadvantage. And lots of time these patients in the later stages might be found to be wandering aimlessly. I mean, it's not that his son kicked him out. He went out of the house and he doesn't know where to go. He maybe went out of the house thinking that, I mean, son is thinking, I thought my father went out for his morning walk. A big old man, they tend to go for walks regularly. So he says, my father earlier used to go for a walk in the morning, in the evening. I thought he had gone out for a walk. He did not return home. And turned dark, and we are searching for him everywhere. And then we found him sitting in the park alone. He was carrying an expensive cell phone with him, but he doesn't know how to dial. He doesn't remember the mobile phone number. He does not even remember the passcode on the mobile phone, right? Nowadays we have a passcode on the dial pad of a mobile phone. So it doesn't remember those numbers. So his son is saying, I was so scared for my dad. He's sitting in the park. It's late in the evening. Somebody might have tried to snatch his phone, try to hurt him, maybe try to rob him. And I mean, this is going to be a recurrent affair, wandering aimlessly. And then later part, they'll start developing delusions. They might be disinhibition. This guy, as I was saying, no, might be wandering in a semi-naked state, and he might be touching his genitals, or he might be doing masturbation activity. And I mean, family members are aghast that the guy is naked or semi-naked and is touching his genitals in front of other people. So disinhibition would be present. They a lot of them will develop shuffling gait. Parkinsonism like gait can be sometimes present in these patients with presence of mutism. He'll not speak also subsequently, and then the person will become bedridden, incontinent, and will finally die because of aspiration pneumonia. So you can understand, I was describing about those great world leaders with the best medical care available before them. And those leaders had to make big, huge decisions. Like Ronald Reagan, I was talking about. I mean, he had a nuclear power, nuclear bombs at his disposal, and he had to keep cool. I mean, obviously, once he developed Alzheimer, he was out of presidency. But I'm trying to tell you is he was leading a nation which was a nuclear power, fighting with the USSR, the Soviet Union. Or our Atal Bihari Vajpayee sir, he was fighting against Pakistanis for the Kargil war, right? So he had to take big decisions whether how the military should be responding. So you can understand from that stage where they were like at the top of their game, where they were at the top of their performance, where they were deciding fate of a country, not even of a fate of of a small province, fate of a huge country. From that state to this kind of a disability where a person is wandering aimlessly in an incontinent state, in a semi-naked shade, unshaved, unhygienic, bad smell from the mouth. I mean, you can understand the deterioration that I'm talking about. So let's now focus on the workup for this condition. Coming to the workup of these patients, one of the initial tests which can be done in these patients is MMSC, that is Money Mental Score Examination. In mini mental score examination, the maximum score possible is a total of 30. And if a person would be getting a score of less than 24, that is when we're gonna say that the person is having dementia. And obviously 21 to 24 is called as mild dementia. Between 10 to 20 we say moderate dementia, and less than 10 would be severe dementia. I mean, less than 10, I would say patient would be so incontinent, wandering aimlessly, that even a non-medico can be making a reference that I think that my dad or my family member has Alzheimer's disease, and your skill is mainly to pick up those mild to moderate ones as well. However, mini mental score examination or MMSE is useful for diagnosis of dementia, not to be answered for Alzheimer's disease. You see, we can be having even pseudo dementia, because lots of time patients with depression might be underperforming in a mini mental score examination. In fact, depression is, this is again another question that I'm handling. The question will say, which of the following will contribute to development of pseudo dementia, that is depression, because persons with depression may deliberately underperform with respect to MMSE score. So what are the tests that are available for mainly identification of Alzheimer's disease? Well, we'll try to use technology to our advantage. So we'll be using a FDG PET, and the FDG PET will be showing a decreased metabolism with respect to two areas of the brain, that is the parietal lobe and the temporal lobe. This itself a question, because see, in frontotemporal dementia it would be frontal and the temporal lobe, that is Pick's disease. But when it comes to uh, per se the answer to be given for Alzheimer's disease, your answer would be hypometabolism in the posterior parietal lobe as well as in the temporal lobe. And I'll just repeat the features again. For temporal lobe involvement, that is hippocampus getting involved, neocortex subsequently, it would be amnesia. And for the posterior parietal lobe involvement, the dominant and the non-dominant side will be getting aphasia and apraxia in the patient. Now we are having more better types of PETs available, which can actually identify amyloid PET. Though amyloid PET is to be interpreted with a bit of caution, because amyloid A beta amyloid deposition can even be seen in the blood vessels of the brain in old age, and you're aware of condition called as cerebral amyloid angiopathy that can cause lobar hemorrhage. Cerebral amyloid angiopathy can be cause for development of stroke in non-hypertensive, non-diabetic patient, causing a lobar hemorrhage, and is discussed in the topic of stroke CAA. So I'll repeat once again. We read about A beta amyloid deposition in the neuritic plaques between the neurons, but A beta amyloid deposition is also present in the blood vessels in cerebral amyloid angiopathy. So the interpretation needs to be made with a bit of care. Then another PET that we have is tau PET, which will be using special dyes that would be like fluorotuacipir. And apart from this, anyway, we have biomarkers also available. The biomarkers can be turning out to be positive, like CSF A beta 42 levels can be found to be lesser even. I mean, this biomarker can be positive even 20 years before the development of mild cognitive impairment, where the person and his family members were saying that, okay, my family member has become, it's tend to become much more forgetful. So I mean, these biomarkers are anyway to be remembered: tau PET, amyloid PET, and CSF A beta 2 amyloid levels. And these values of CSF A beta 2 are lesser, or they might be a ratio like A beta 42 divided by A beta 240. That might be written. I've written that already, so no point of writing that again. And as far as doing a MRIs in these patients is concerned, all I can say is that MRI in early stages of Alzheimer will not pick up anything. In the later part, yeah, it can pick up cortical atrophy and the ventricles will look relatively bigger. The main advantage of doing a MRI will be, one, to rule out frontotemporal dementia, or ruling out Creutzfeldt-Jakob disease, where you get uh, insular ribbon cortex appearance. It will also help in ruling out NPH, that is normal pressure hydrocephalus. So advantage of doing a plain MRI is only to rule out a couple of other differentials that might be like in normal pressure hydrocephalus also there is a presence of dementia, but that would be a reversible dementia. That's itself a very peculiar term. So when I introduced a new terminology, pseudo dementia, and I mean that's seen with depression, and then I also mentioned reversible dementia, though reversible dementia is also seen with hypothyroidism as well. So I'll just enumerate that on the subsequent slide, but at the moment I've just talked about a couple of tests which are available for diagnosis of Alzheimer's. There can be a lot of bias while trying to interpret many mental score examination because the test is in English. So you'll have to translate it into local language of the patient. And this test would be basically testing the working memory of a patient. Working memory would mean that you will be asking the patient to spell a particular word backwards. Like we'll usually give a 4 or a 5 letter word, and the 5 letter word has to be spelled backwards. Then episodic memory is like whatever I told you just a few seconds back. Like if I ask you what did you eat for your breakfast or what item did you eat for your lunch, you are able to immediately recall that. Now here, because see, a person might give you any random item. He said I ate XYZ item for lunch. You were not physically there. So how would I test out the episodic memory? I'll mention three words before the patient. Like I might say dog, and then I might say a parrot, and then I might talk about a color blue, and I'll ask the patient to repeat the words that I said. That is a dog and a parrot. That was an animal and a bird and a color. And a person should be able to tell me this. Then we'll ask the patient to do serial calculation. Like we'll ask him to subtract 7 from 100. Then whatever value that will come, we'll ask him to again subtract 7. He might make a small mistake, maybe because of somebody might not be good in mathematics. But at least if he's trying to do this activity, that means we are trying to test the attention and the calculation capability of a patient. Then to check out the language comprehension, you will ask him naming of objects. So you can ask him, like you can show him a watch, you can show him a pencil or a pen, and you can ask him how to name it. You might even show him a geometrical shape like a pentagon and ask him to draw intersecting pentagons. So we are trying to check out the various aspects with respect to memory. And as I said, if a person is scoring less than 24 on a mini mental score examination, it is suggestive of presence of dementia. Though for Alzheimer's disease, we have much more specialized tests available, which would help us in identifying the disease even before the onset of disease manifestations. Now, as far as the treatment of this condition is concerned, now we have a monoclonal antibody. The name of this I was keeping it to a reserve towards the end. You would have read it anyway in your psychiatric classes. That is aducanumab, and we would be giving IV infusions of this. The IV infusions would be given on a monthly basis, that is 4 weekly, and there would be total of 7 infusions that would be given to the patient. Well, who are those candidates where aducanumab would be useful and what would be the mechanism of action? Then this monoclonal antibody has been shown to bind to that A beta amyloid neuritic plaques, and thereby it decreases the level of A beta amyloid accumulation in the brain, and thereby reduces the burden of the disease per se, and at least prevents the further progression of the disease. Clinical studies have shown that aducanumab should only be used in patients with mild cognitive impairment or early dementia. So it is not recommended for like that late presentation. Like if a patient has already gone into that stage where he's wandering aimlessly, he's incontinent and is disheveled, and that late manifestation that I'm saying, then aducanumab would not be working. It has to be started at the right time. Timing is important in this case. That who are the candidates where it has shown a benefit? It has shown benefit only with respect to patients who have recently gone into mild cognitive impairment and early dementia, and should not be prescribed to patients who have already gone into the late presentation. The couple of side effects of aducanumab as well, that is in the form of vasogenic cerebral edema. And apart from vasogenic cerebral edema, second side effect that can be occurring is microhemorrhages. So obviously, I mean, every cloud has a silver lining, and then the cloud has some problems as well. So these are the two problems which are to be remembered. And the traditional drugs that we have been using for a very large amount of time for this condition are like donepezil. I mean, in earlier times, this was the drug of choice for this condition. Now, obviously, the first spot would be answered as aducanumab. Then is the aspect of donepezil, and then other drugs that are used apart from this would be rivastigmine and galantamine. Most of the time, the diagnosis of Alzheimer's disease would be occurring in the medicine unit only, and then subsequently the patient might be referred over to a psychiatrist. So most of the time in government hospitals, you will notice patients being started on rivastigmine and galantamine, and then being sent over for specialized management subsequently. A lot of these patients will have to give up driving subsequently, and there is a high probability of these patients ending up with accident. Not that he'll hit on the brakes later, or it's not that he's going to accelerate too fast. It's just that once he gets lost, he'll tend to get distracted. He can't find the way across, and therefore his concentration span can decrease. In India, where the traffic is so crazy with nobody following the lanes, they can end up with a pretty severe amount of accidents as well. Then the last drug that I'm mentioning is only for pharmacology perspective. I mean, you know that Acrine has been withdrawn from the market, and that withdrawal is mainly because of the hepatotoxicity. So that's again a pharmacology based question, that which drug is withdrawn from the market. That is Tacrine because of the hepatotoxicity component. And these are the list of the drugs that we can be using for management of these patients. Subsequently, let's do a quick recap. What is the leading cause of cortical dementia? Then it is Alzheimer's disease. So if obviously it's not given, then you have to think in terms of frontotemporal dementia also, which is also a cause of development of cortical dementia only. If it's a subcortical dementia where basal ganglion thalamus is involved, then you have to remember at least three: Parkinson disease, then there's Huntington's chorea or Huntington's disease, and then AIDS related dementia. So though for cortical dementia, I have mentioned regarding the causes right on the very first slide with respect to Alzheimer. So on a comparison basis, they can ask you about causes of cortical and subcortical. And though this is artificial classification, was mentioned in the older versions of the book, so I've decided to speak about it. However, if they give you a combination of dementia with myoclonus, then you have to think in terms of Creutzfeldt-Jakob disease. And in case he mentions regarding consumption of beef or tainted meat, then you know that he's talking about variant Creutzfeldt-Jakob disease. It will obviously be advantageous to you if he talks about the EEG finding of Creutzfeldt-Jakob disease, where we would be having periodic sharp wave complexes or PSWC, as has been discussed in the EEG section. In case he's talking about dementia with chorea in 50 years of age, we'll think in terms of Huntington's disease. These are just, I would say, pointers towards the diagnosis of these conditions. Then for pre-senile dementia, I've already told you that patients of Down syndrome can die early because of congestive heart failure or because of pneumonia. But if they survive beyond 35 years of age, that's where pre-senile dementia can be developing. And then very peculiar data that I'm mentioning is reversible dementia, that is normal pressure hydrocephalus. Obviously, there's a huge list for this also. But then the minimum that I expect you to remember at this moment would be normal pressure hydrocephalus with hypothyroidism. These are two examples of reversible dementia. As far as normal pressure hydrocephalus is concerned, we are all aware of the Hakim's triad, where the person will be having that classical wacky, wobbly, and wet appearance. So let's look at the features of Hakim's triad, which can be remembered by a mnemonic by the name of AID. Alphabet A would be for that ataxia. So when this person will walk, his gait would be abnormal. There would be imbalance in this patient in a sense that his trunk will be swaying, and when he will walk with short shuffling steps, feet close together, but the hips would be externally rotated. So as you can see, the external rotation of the hips is visible with respect to the position of the foot of the patient as compared to a normal person walking. I mean, a Parkinson disease patient will anyway take short shuffling steps, will tend to, walk with feet close together and the body stooped forwards. Automatic arm swing would be reduced. But in a normal pressure hydrocephalus, we would be having a magnetic gait. That's why the ataxia component or the wobbly appearance with that lurch in the trunk would be present. Then is urinary incontinence, which is again because of pressure on the paracentral lobule, which helps in control of the urinary bladder. So incontinence of urine would be seen in these patients. That is why I was saying the word wet and wobbly. And then apart from wobbly, he'll also be having wacky. That's because the dementia component is coming up. So either you can remember it as the traditional word wet, wacky, wobbly. That wet is for the incontinence, the wobbly is for the ataxia, and the wacky is for the dementia component. Or I think the more specific details is what I mentioned for NPH, that is normal pressure hydrocephalus. In NPH, if we remove CSF of the patient, then there will be an improvement in the gait that we call as a Fisher's test. Fisher's test means that we perform a lumbar puncture in this patient, we remove over 20 to 30 ml of CSF, and subsequently to this therapeutic removal of the CSF, there is a gait improvement. So we call it Fisher's test, which is not only gonna be having a diagnostic, it's gonna be having a diagnostic importance, but even a therapeutic importance as well. There is a gait improvement that that I was saying the patient is having wet, wacky, and wobbly status. So the wobbly status would become relatively lesser. The great improvement is seen after doing a lumbar puncture, where a therapeutic removal of about 20 to 30 ml of CSF would be done. It's safe to remove that amount of fluid CSF because that would be produced in next 1 hour itself. I mean, the rate of CSF production is about 20 ml per hour produced by the capillaries in the choroid plexus. So these are the details that I would like you to remember for this topic. Especially, I've tried to cover that a couple of one-liners in towards the end of this video, which also deserve the respect that they need, apart from obviously the core topic of Alzheimer that I have discussed with you.